Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Hello everyone, this is Dr. Nerd, and today we're going to be talking about neoplasia. So let's start with a case. You can pause the video and take your time reading it. I'm just going to go over it briefly. So here we have a 65-year-old woman essentially complaining of fatigue, fever, unusual weight loss over the past 6 months. She has a history of smoking and mentioned that she noticed a mass in her left breast. So upon physical examination, there was found to be a mass in the left breast and a single palpable axillary lymph node. Imaging confirmed the mass, and it was 2.5 centimeters in diameter. And a mammographically localized surgical biopsy was done. It revealed a grade 3 infiltrating ductal carcinoma with some associated ductal carcinoma in situ. Patient underwent a modified radical mastectomy to remove the mass and axillary lymph node dissection. So when you see all of these things, this constellation of symptoms, what comes to mind? And so first we see the constitutional symptoms, which are fatigue, fever, unusual weight loss, and there's also night sweats, but it's not mentioned here. And so those immediately make you think of something like cancer, infection, and the fact that there was a confirmed mass in the left breast clues us into the fact that this patient had breast cancer. And so today we're going to be talking about cancer or neoplasia. And in order to understand this case better, we're going to take it step by step. And to do that, let's first define neoplasia. So what is neoplasia? The prefix neo means new. And so neoplasia would be defined as uncontrolled, disorderly proliferation of cells. And so this growth would result in a tumor or a neoplasm. So now let's take that a step further and define a neoplasm or a tumor. And so that is an abnormal mass of tissue with autonomous, uncontrolled, and excessive growth. So these three words that are bolded here are very important to keep in mind. Autonomous, uncontrolled, and excessive growth. So when we say autonomous growth, that's very important because that hints to a very important underlying principle, which is monoclonality. I'm going to touch upon this a bit more later, but I'm going to introduce it now. So when we say monoclonality, that means all of these cells come from one ancestor cell, one origin. So those are measured, or you can tell that all of these cells come from one origin by measuring something called G6PD isoforms. And I'm going to touch upon that later, but I want you to keep in mind that neoplastic cells are autonomous, meaning they are monoclonal. And you're going to have uncontrolled and excessive growth that, this is the key here, persists after the cessation of the stimuli or stimulus which caused it to occur. So I'll give you an example of smoking. So let's say you have someone like the patient in this case who has been smoking for 50 years and they decide to stop smoking. But in the process of them smoking, they triggered inflammation, chronic inflammation, a lot of mutations. We're going to touch upon that in a bit. And that led to this development or formation of a tumor. Even if they stop smoking at this point, that does not erase all of the damage to the cells that happened prior, meaning that you're not like the cancerous cells in this case would continue to proliferate even after the trigger or the stimulus stops, which in this case is smoking. So now let's take a deeper dive and look at this big question, which is why does cancer occur? In order to do that, let's define it. Cancer is a genetic disease caused by DNA mutations that are acquired spontaneously or induced by environmental insults. I apologize for the typo. Please ignore that. So let's look at this. We said environmental insults, like what? Stressors in the environment, for example, chemicals, pollution, smoking, radiation. You can think of a lot of different things, unhealthy diet, chronic inflammation in the body. Those can trigger excessive cell growth as a reactive type of cell growth. And that can also have the potential to damage DNA, whether directly or indirectly. And so what happens with cancer is that these mutations are going to accumulate over time. You're going to get one trigger that's going to cause excessive cell growth or damage DNA. And then these cells with more damaged DNA are going to grow even more. And so you're basically having the snowball effect and you're accumulating mutations over time. And you also have a genetic factor. It's always important to ask about patient history, particularly, let's say you suspect a cancer, you have to ask, okay, do you have a family history of cancer? And that's because mutations are heritable, so they can be passed down from your parents to you, and so that's very important to keep in mind. And here it's mentioned, mutations can be heritable. We talked about that, and these changes are subject to Darwinian selection. What is that, and why is that important? Well, if you've heard of survival of the fittest, we're essentially applying this principle to cancer cells. So the cancer cells that survive tend to have the strongest qualities, the strongest characteristics. Essentially, they are quote unquote the fittest cancer cells, which is what makes cancer dangerous. And essentially, because of these heritable mutations that can occur as well. So let's take that as a transition into the basic principles of cancer cells. So essentially, what makes them the fittest, if you will. One is self-sufficiency. And so what that means is they do not require hormones or growth factors. They can independently sustain their growth. They can produce their own growth factors, and that is why they grow independently of all the other body tissues. And so that goes to the next part, independence. They do not require other cells to grow, because keep in mind, this type of growth does not have a specific function. It's just growing and it just won't stop. Very important, we have evasion of apoptosis. We know apoptosis is programmed cell death. So these cells don't respond to apoptotic stimuli, which is why they keep growing and growing and growing and growing. And that brings us to the next point, is that these cells also have the feature of immortality. And the reason that occurs is there has been like a cell line, if I'm not mistaken, since the 1950s, and it's still alive till today because they're cancer cells, they're immortal, and they do that by an enzyme called telomerase, which elongates the telomeres, which are like the parts at the end of the chromosome. And so that prevents the chromosomes from shortening. And so that gives these cells the features of immortality. Moreover, we have neoangiogenesis. So this looks like a big word. Let's break it down. Neo means new. Angio refers to blood vessels, and genesis means creation. So the creation of new blood vessels. And so this is important for tumor cells because remember, they're growing. They have high metabolism, meaning they need a lot of nutrients, they need a lot of oxygen. And so they create their own blood supply by the overexpression of VEGF, or vascular endothelial growth factor, in order to get that. And you also have, again, I touched upon it a bit, aberrant metabolism. So these cells have a high metabolic requirement. They're doing a lot and they're growing really fast. However, this metabolic requirement, or the metabolism of these cells, is independent of your body's metabolism. So it's not going at the same pace. And last, but definitely not least, is evasion of the immune system. So these cells hide from the immune system in order to protect themselves and in order to stay alive, essentially, in the body. And so I'm not going to touch upon these in details, but you're free to read if you'd like. So let's take a step back. Let's go back to our case. So we said we suspected breast cancer in this patient, but one thing they mentioned here is that it revealed a grade 3 mass when they did biopsy. What does that mean? What is grading, tumor grading, and how does it differ from tumor staging, if you've heard of that as well? So in order to do that and understand that, we need to know that tumors are classified into two broad categories: benign tumors and malignant tumors. So benign tumors stay in their primary location, essentially, and they do not spread to local structures usually, or distal parts of the body. So they're not invasive. They can compress structures, but they're not invasive. That's the key here. And they tend to grow slowly and have distinct borders. So these are not as dangerous as malignant tumors. And if you see something with the suffix oma, this is not a rule, like there are exceptions, of course. But let's say if you're talking about fat, a lipoma is a benign tumor. And as for malignant tumors, they grow uncontrollably, they spread to other tissues, and they invade distant sites. These are considered cancerous, and they have a feature of metastasis, which is where they spread to other parts of the body, whether by the blood, which is called hematogenous spread, or the lymphatic system. And so they tend to be a lot more dangerous, and malignant tumors is essentially what you fear. And they have a much poorer prognosis, of course. So now let's go back. Now that we understand that, what's the difference between grading and staging? Grading is the degree of differentiation of tumor cells. So what does that mean? When we're looking at tumor grading, you're looking at it histologically. So remember how we said that all tumor cells are going to come from one single origin, one single cell. So in grading, you're looking at how similar these tumor cells are to the original cell. If they're very similar and they look relatively normal, you consider that a well-differentiated tumor. And the less differentiated, or the more messy, let's say, the cells look, the more likely this lesion or this mass is to be malignant. And then you have staging. So staging is how far the cancer has spread according to the clinician's knowledge. So high-grade tumors tend to be more dangerous. Those involve lymph nodes, like the one seen in this case. This is a resection of the breast. This is also a tissue in our patient. So you can see this is the tumor. It has spread. It is a metastatic tumor because it's invading other parts of the breast. You can see a part of it in the lymph nodes. You can see the retracted nipple, which is also another feature of breast cancer. And so high-grade tumors involve the lymph nodes, and low-grade tumors do not. So this is just another way to visualize the grading versus the staging. So this is grade 1, grade 2, grade 3, and you can see how progressive the cells are. See, this is more disorganized. The cell type does not look the same as it did here. And here is intermediate. So this is well differentiated. This is moderately differentiated. These would be more poorly differentiated. And staging, again, is how far the cancer has spread. So stage 0 is no spread. Then you get the gist. Stage 1 is 1, 2 is 2. And again, there's more specific ways to elaborate upon this, but it's not the topic of today. So now we get to the important part. How do we differentiate tumors from other forms of growth? There are all these words in front of you and they all look the same: hyperplasia, metaplasia, dysplasia, anaplasia. Let's break them down and understand them bit by bit. Hyperplasia is just an increase in the number of cells. These cells appear normal. However, they do have eventually the potential to turn into cancer, but at this moment in time, these cells appear normal. And then you have metaplasia, which is when you have one cell type replaced with another cell type. And this is reversible. That's the key here. And then metaplasia can progress to dysplasia, which is again reversible, disorderly, but non-neoplastic growth of epithelium. Reversible, disorderly, but non-neoplastic. However, it can be considered like the precursor to having a neoplastic mass. Anaplasia is lack of differentiation. So at this stage, we would consider it a cancer. You have lack of cell differentiation, so they no longer look like the mother cell type, and this is more dangerous. So this is just a picture to help you visualize. These are the normal cells. This would be our hyperplasia, our metaplasia, and our dysplasia. So let's look at the normal epithelium versus a dysplastic epithelium. So normal epithelium is going to show a feature called maturation towards the surface. So as you go here, you can see that you're starting to lose your nuclei and the cell type looks like it's changing. However, in dysplasia, which is this side of the slide, you lost that completely. The top here no longer looks like that. You have nuclei. The cells are of different sizes, which is called pleomorphism. The cells appear smaller and the nucleus is larger. That's called hyperchromatism. where you have a decreased NC, or nucleus to cytoplasm ratio. You also have, which is not very visible here, but loss of polarity, so loss of the normal cell orientation. And of course, you have increased cell proliferation, or more mitosis here. So those are the dysplastic features, or features of dysplasia. But remember, monoclonality is the key here. I said I'd touch upon it again. So monoclinality is how you differentiate, let's say, a benign tumor from normal tissue hyperplasia. And so you have a J6PD isoform, which is found in every type of cell. And so you measure the ratio. If, let's say, you have a lot of one specific isoform, that tells you that all of these cells came from a single cell. And that is more indicative of this being a tumor. However, if you see the ratio as 1-to-1 or normal, then that tells you that this is probably tissue hyperplasia, not necessarily a tumor. So that's just very important to keep in mind. So let's go back again. This case mentioned that there was a ductal carcinoma in situ. What is that? And how does it relate to tumor growth? So this is the dysplasia we just looked at. Okay, and remember, this does not involve the whole epithelium. We're seeing the dysplasia here towards the basal cell layers. Versus carcinoma in situ, you have something called full thickness dysplasia. You can see how large this nucleus is. That's considered an anaplastic cell. Remember, now these are, you have lack of differentiation. Okay, so these are anaplastic cells and full thickness dysplasia. And this is considered to be a pre-malignant condition. However, keep in mind that at the bottom, the basement membrane is intact. These cells have not penetrated through the basement membrane and have not invaded nearby structures yet. However, they're pre-malignant. They have the capacity to do that. So this is just to show you a timeline of how the tumor may appear. So this is just signifying the accumulation of mutations over time. And so this is the early stages where we'd have the normal epithelium, hyperplasia, and then hyperplasia can turn into metaplasia. That can turn into dysplasia, again, with the accumulation of mutations over time, with more and more environmental stressors and genetic predisposition. That dysplasia, once it involves the full thickness of the epithelium, we call that carcinoma in situ. And then that carcinoma in situ can turn into an invasive carcinoma. At this point, we have a malignant cancer on our hands, and that is very dangerous. So that is the progression of tumor growth. And that brings us to the end of our lecture. And I just wanted to add a quote here. There is one and only one goal for all of us: to ensure that all our intellectual efforts are directed towards the relief of humanity's suffering. And I think that's very important to note with a topic as important and as devastating as cancer. I hope you enjoyed the lecture. These are the resources I used. If you have any questions or you have any concerns, of course, feel free to contact us at Dr. Nerd, and stay tuned for the next recording.